Hello and welcome to this video about the stepwise approach to airway management. Before starting our airway management, we'd have already done our kit check, we'd have already done our dynamic risk assessment, so our scene assessment, we'd already done our level of response, so our AVPU checks and everything appropriately, and then we're going to concentrate on just the airway in this video and adjuncts that we can put in. With any airway manoeuvres, we should always have the appropriate PPE on. So we should consider having a mask, having our goggles, and having gloves because of the potential of bodily fluids in the airway. So this is what we're going to do. Just as a reminder, at the moment where we are currently in the pandemic, we should be wearing level 3 PPE as per government and local guidelines for all airway manoeuvres. So this video is not going to be wearing that level of PPE. So just a reminder, why are we concerned about the airway? Well, if we remember from the previous video how we breathe, that mechanism of our diaphragm lowering and diaphragm going back to its natural position is what increases the thoracic cavity space and drawing that air in through the airway. So it's important that we keep the airway clear so that air can come in and out. And most importantly, so the body can get rid of that carbon dioxide that it's built up from cellular activity. If we look at the airway from the outside in, we're looking at the lips, the teeth, the tongue, the hard palate, the soft palate, the uvula, the little dangly bit at the back, and then got the tonsils at the side, and then we've got the tongue. Now, where we're looking in here, the most important thing for us is this epiglottis. So we've got the follicular space above the epiglottis, and then below it we've got the larynx, and then we've got the opening to the trachea here, and inside there you can see the vocal cords. What we want to avoid is this one at the back here, which is the esophagus. So the problem is we've got the trachea at the front, the airway, and the esophagus, the food pipe at the back. Now, normally when we breathe and our diaphragm lowers, we draw air in. So we're not worried about any issues with that airway unless it's closed. When we start artificially breathing for someone else and we start forcing air in, then we could be putting some air into the esophagus. Now, for this video, we're only talking about basic life support, BLS. So as it is quoted by the J.R. Calkin in the Resus Council, basic life support is the basics with the use of a bag valve and mask, a BVM, and simple adjuncts such as an OPA, an oral pharyngeal airway. We're also going to go through an NPA, the nasal pharyngeal airway. But let's start with the real basics. When we approach a patient and they appear to be unresponsive, we may have to open the airway. But prior to opening the airway, we need to inspect, and this is important. So making sure I'm wearing my appropriate PPE for this. My patient is on the floor. I've gone through my basic checks. They appear to be unresponsive. Now, I've got two main methods to open the airway. From the side, I could use the head tilt and chin lift. And from above the head, which is my preferred position, I could use the jaw thrust method. But whichever method we're doing, before we open the airway, it is important that we inspect the airway and we're looking for any foreign object that may be in there, be it liquid or a solid. So from the side, just supporting the head, I can simply pull the chin down to have a look inside to see if I can see anything obvious. But my preferred method is above the head, and I will start the process for the jaw thruster coming round the back of the ears, finding the angles of the jaw but not lifting the jaw at this stage, but using my thumbs to open the mouth, which allows me to inspect the airway before I actually open the airway. If I do identify anything in there, I could use postural drainage by rolling the patient away from me to allow anything to drain out, or even the recovery position, or I could use my manual suction equipment, which we're going to have a look at now. So here is an example of manual suction equipment. These come in lots of different sizes, shapes, colours, manufacturers. Most of them these days are single patient use because of infection prevention. This is an older style one, which traditionally would be cleaned out, but I wouldn't anymore. Once this is used for real, I would then use this single use and dispose of it. With the catheter, I'm just using a size 8 nasal pharyngeal as a catheter, which again would be in a sterile packet when I first opened it. And all I'm doing is using it as a catheter to go in. Now again, in the past we would have done other methods of this, but the most current way that we teach is you only put the tip in as far as you can see. So you're making sure you've always got visual sight of the actual tip of your catheter. So no need to measure, because when we go in we can still see the tip, and then we can suck only on the way out for a maximum of 15 seconds. And once we've sucked that out, if we needed to go back in again, we can repeat by going in under direct vision, so we can still see the tip, and then only sucking on the way out for a maximum of 15 seconds. So that's our manual suction equipment. I'd keep this handy in case I needed it again, but once I'm finished, this is now going to be disposed of as clinical waste. Once we've made sure the airway is clear, whether it was postural drainage or manual suction, I can now open the airway. Now, if we look at the traditional way of opening the airway, and I'm just going to use this for a second, is the head tilt, which tilts the head back, but as you can see, doesn't really do a lot for lifting the tongue off the back of the throat. So the head tilt's there, followed by a chin lift. The most important part is the chin lift, because as we lift the chin, and let me just change to here, as we lift the chin, we're lifting the bottom layer of teeth. And from that model we looked at earlier, as we lift the bottom layer of teeth, that is what lifts the epiglottis and opens up the trachea. It's the tongue which rests on the epiglottis which can close the airway. So that traditional head tilt, chin lift, the most important part is the chin lift. But what we can do is just the chin lift on its own, but not really from the side. This is where the jaw thrust will come in, and this is what we're going to look at now. With the jaw thrust, as I mentioned earlier, I would always use my index fingers. I'll start at the top of the patient's ears, and as I come around, my pads of my fingers are against the back of the ears, the tips of my fingers against the skull, and then as I come around, as my finger drops off the skull, that puts me on the angle of the jaw. Not where it looks like on the mannequin, but that's where it is on there, and that is where I can lift. So again, if I bring it back to this skull, as I come around the back of the ears, as I drop off the ears, I come into the angle of the jaw. Now, most people will see this prominent part on the mannequin or the real person, but this is the area where we can actually lift the jaw. Doing the jaw thrust, that stops us from actually rotating the head back with the head extension. And this jaw thrust will actually lift up the tongue off the back of the throat. So that's going to be my preferred method, working from above the head. So when I come in, I'm going to find the angles of the jaw. I'm going to open the mouth with my thumbs to inspect the airway. And depending on what level you're at, some people will now palpate the C-spine at this stage before they actually open the airway. So they'll feel down the vertebrae in the cervical spine to check there's no abnormalities. But once we're happy, we open the airway using a jaw thrust, and then we can look, listen and feel for any breathing for up to 10 seconds. And again, some people will maintain an airway whilst palpating a carotid pulse, so we can do it that way. So just so you can see it on this side, as I'm still holding the airway with a jaw thrust, I can palpate a carotid pulse on the other side, and some people will just look, listen and feel for up to 10 seconds depending on what level you're currently working at. If I can't get an airway, I may have to have slight head rotation, but if I think there's C-spine injuries, the flatter I keep the head, the better, and using a good quality jaw thrust is good. The next thing I'm going to do, now I'm happy that the patient is breathing, is look at managing their airway. And one of the things I can do is place something like a blanket underneath the head of the patient, and so I'm raising the head about 2 centimeters from the ground, which will be a much more natural position and will already start to open the airway. So we're already part of that stepwise approach. The next thing I can look at then is a nasal pharyngeal. Now, nasal pharyngeals will come in a variety of sizes, 6, 7, a size 8, and again, different manufacturers, different kind of qualities, different colours and stuff, but they all have the same kind of traditional method of using it. So if we look at our nasal pharyngeal, it's already got a curve to it, and there's a chamfer on the end. We always start with that chamfer towards the septum in the nostrils. So the right hand nostril, which is normally slightly larger, is where we're going to start. And we want to get some lubrication. So one way you might do it is by putting some lubrication onto the back of your glove, getting some lubrication onto the nasal pharyngeal, introducing it into the right nostril, and then as we go in, we come up to push the nasal pharyngeal down, and it will go all the way. A nice big wide ring on the end to stop it going any further. But if we look into the airway, and I don't know if you can see it in there, but we can see it at the back of the oral pharynx there. So that's a nasal pharyngeal. We could put one in each side. If the patient didn't like it, we could remove it by sliding it out. Now, we do want to avoid a couple of things with the nasal pharyngeals. And I'm just going to get a smaller size out to demonstrate this. So if we think our patient has got a base of skull fracture, then we're going to avoid using a nasal pharyngeal. But the other thing is, when we introduce the nasal pharyngeal, it starts going up the nose, and lots of people think we should carry on pushing up. That's not the case, because if we look up the nose, it kind of stops. So if I was pushing it directly up, it wouldn't go anywhere. What I actually want to do is, after introducing it, it comes down, so it goes straight down, so it's pushing straight the way down, because the back of this is the hard palate. So actually, when it goes in, we want to come up, so we're pushing straight down rather than going up the nostril, which may be the way that it looks like. So when it comes in, we go up and then we push it down the hard palate so that it sits round the back, comes out into that pharynx area there. The nasal pharyngeals are a really good device. They can be used on semi-conscious patients as well as unconscious patients. They will tolerate it if they wake up as well. The next piece of equipment we're going to look at is the oral pharyngeal airway, or the OPA. Now, these are important that we measure them correctly. Now, the correct way to measure it is what we call hard to hard. And when we mean hard to hard, we're talking about bony structures. So the correct way to measure it is from the angle of the jaw, so from this bone here, to level with the incisors. So we draw two vertical lines, and we want an OPA that fits in between those there. The way in which I will do this is I will do my jaw thrust, find the angle of the jaw, and once I've got that bony promenade there, I will then place the OPA onto my finger, still in its packet, the correct way round, making sure that that flange is level with the incisors. If I show you a different size one, so I come around, place my OPA there, we can see how this one would be too high above the incisors, and this one is possibly too low for the incisors. So the right size for this mannequin here would be this orange one, the middle one, where the flange is now level with the incisors there. Once I've measured, keeping it round the correct way, I can open the oral pharyngeal airway and just pinch the top, so I'm not touching the whole of it. I remove it from its packaging, I then invert it, insert it, rotate it, locate it. If they gag on this, it will roll out forwards. So I'll just show you again, this time not using the packet. So I've measured my OPA, I've got the correct size, take it out the packaging. I'm then going to invert, insert, rotate, locate. And what you'll notice is, as I rotate, it goes down and round like a corkscrew. If they gag on it, it rolls out forward. So these are the basic airway adjuncts that we've looked at. So first of all, we come across, we supported the head, we inspected, and if there was something in there, we used postural drainage or our manual suction to remove it. We then opened the airway and we checked for breathing for up to 10 seconds. The patient is breathing, so we're going to manage their airway in a stepwise approach. We could use a nasal pharyngeal with the right nostril first, and that comes in and that slides down with some lubrication on. We could then measure and insert our OPA, and now the patient can breathe. If their saturations, their oxygen saturations were below 94, we might put oxygen onto them. And if their respiratory rate was below 10 or above 30, we may need to ventilate the patient, and that's where we can use our bag valve and mask. And to use our bag valve and mask, we place the mask over the mouth and nose with the adjuncts in place. We use our two thumbs on the mask, so our thumbs pointing to the patient's toes and our index fingers under the angle of the jaw to do a jaw thrust into the mask and hold that in place. So the two-person technique is the gold standard. If you are on your own, you can do the solo technique, which would be the anaesthetist grip, which would be a C, which holds the mask in place, and an E, which pulls the jaw up. The most important thing is your middle finger is in the middle of the chin. So get your C on the mask, middle finger in the middle of the chin, other fingers around the jaw, pull the jaw up into the mask, and then you can ventilate. This would be exactly the same as if you was using a traditional pocket mask on a patient, maybe for ventilation. So we would pop this out. This would then go over the top of the mouth and nose, both thumbs pointing towards the toes, index fingers under the angle of the jaw, pull the jaw into the mask so that you can ventilate them. And this is the gold standard for the two-person or for using the pocket mask to manage the breathing. We do hope you've liked that airway management video. Don't forget to click here to see our most recent video, click on here to subscribe, or click here to watch another video of ours.